Today we are going to talk about mood disorders, starting with depression. Before we get into the symptoms of depression, just a reminder on the difference between mood and affect. So, mood is a pervasive and sustained emotion that influences one's perception, is based on life events, and is generally time limited. Whereas affect is the range of emotional expression that an individual is capable of. So, for example, a flat affect would be inability to use any emotional expression. Blunted or restricted would be less than normal expression of their emotion. Labile affect would mean that they're experiencing a lot of emotions in quick succession. And an inappropriate affect is when someone's emotional expression does not match the situation. So, for example, if someone hears that a loved one has passed on, they may start to laugh instead of cry. And that is an example of an inappropriate affect. When we look at depression, the DSM 5 states that an individual must have at least 5 of the symptoms listed here, with at least 2 of them being loss of interest or pleasure and depressed mood. They must experience these symptoms over at least a 2-week period. And the other symptoms, in addition to the 2 that can be included for the diagnosis, are feelings of guilt, low self worth, disturbed sleep, which could mean increased sleep or decreased sleep, disturbed appetite, which could mean an increased appetite or lack of appetite, low energy, poor concentration, and suicidal thoughts or ideations. We know that individuals have different experiences and different statistics of depression based on their age. While depression is less common in childhood, we do know that they can experience it, although children generally experience anxiety more frequently. Symptoms of depression in children generally tend to be more somatic, meaning of physical nature, and it can include things like an upset stomach, a headache. They can also have irritability of mood and frequent temper tantrums. While suicidal ideation and suicide attempts are very rare in children, we do know that they're more likely to use suffocation as a method versus other forms. In adolescence, we do see an increase of suicidal ideation and suicidal behaviors. And part of that is because the exploration of role identity, as well as a phenomenon called suicide contagion, which we'll talk about later. Adolescents typically start to experience depression more based on the criteria that the DSM 5 lists here, where so they're not experiencing it as somatically as they would in childhood. For adults, we know that depression is the highest between ages of 18 and 29. This is often attributed to the fact that during this time, there's a lot of life changes. And we know that whether good or bad, life changes can increase stress in the body as well as experiences of mental illness. Depression is more common in women during adulthood. And in individuals that are diagnosed with clinical depression, they have an average of 5 episodes during adulthood. Depression is one of the leading factors of disability from work. And when we talk about suicidal behaviors in the adult population, we know that men are usually using more lethal means like use of firearms or hanging, whereas women tend to use less lethal means like overdose. Because of this, women are generally less likely to die from their suicide attempts than men are. When we look at the older adult population, we see another spike in suicidal behaviors after the age of 75. And this is often due to chronic illness, aging, lack of generativity, and loss of social support, their family, their friends, and people that they are close with. When we talk about the experience of depression and depressive symptoms in the older adult population, they can often appear very similar to that of a cardiovascular accident or dementia. So it's really important that we're properly screening our older adults for depression. When we look at risk factors for depression, we break it down between modifiable and non-modifiable. Our treatment is typically going to focus on our modifiable risk factors because they're things that are in control of the patient to make changes to. So, for example, you can have environmental stressors such as lack of satisfaction in their job, conflict with others, poor economic status, as well as physical environmental factors like the amount of sunlight the person experiences, how safe the environment that they're in is, Substance use is another modifiable risk factor, as well as irrational thought processes. So these could be things like obsessive thoughts, negative thinking, concrete thoughts, all or nothing thoughts, low self regard, and so forth. Also, lacking rewarding activities can be a modifiable risk factor as well. So, when we have a patient that comes in with depression, we can help encourage them to modify their environment to be a healthier environment for them. We can help them address any substance use issues. We can provide cognitive behavioral therapy or dialectical behavioral therapy to address any of those irrational thought processes. We can help them build coping skills and set goals for themselves so that they're engaging in rewarding activities more often. Non-modifiable risk factors are the risk factors that are out of control of the patient. So while they're still risk factors, they're not things that we can generally do much to address. These risk factors include having a history of depression, having a family history of depression, lacking social support, which in some ways can be modifiable, but we consider it a non-modifiable factor because we cannot control the amount of support that someone's able to give us. Having a medical comorbidity, such as an endocrine disorder, cardiovascular or neurologic disorders, a viral infection, autoimmune disorders, cancer, nutritional deficiencies, and any disease or disorder that threatens our integrity of life or threatens our self esteem is a huge risk factor for depression. As mentioned earlier, being of age 18 to 29 or greater than 75 is a risk factor. Being of female gender, having a deficiency in norepinephrine, dopamine, and serotonin, which makes sense because we provide our patients with antidepressants when they're experiencing depression, and the purpose of the antidepressants is to increase norepinephrine, dopamine, and serotonin. Having abnormal cytokine activity in the brain, lacking love in childhood, losing a loved one, being of certain ethnicities, and of veteran status are all non-modifiable risk factors. When we look at assessment of depression, we want to focus on a lot of different things. First, we're going to look at their physical assessment and their health history. We're going to look at their CNS function, their endocrine function, if they have any anemia, chronic pain, autoimmunity problems, diabetes, are they going through menopause? We're going to be doing that physical assessment, doing diagnostic testing, lab testing. And the main reason that we want to do this is to make sure that there's no medical cause for their experience of depression. When we look at their health history, we're looking for any medical illnesses. How is their social support network? How is their occupation and economic status? Are they able to perform their ADLs and maintain a normal daily schedule? Do they have any religious beliefs? Do they engage in any substance use? Are they victims of abuse, whether physical, sexual, or emotional? And what medications are they currently on? We're also going to assess things like appetite and weight changes, their sleep and energy, their thought content. In particular, we're looking for that unrealistic negative evaluation of things, extreme guilt, ruminating thoughts, disorganized thoughts, thinking in absolutes, as well as possible experience of hallucinations, delusions, or paranoid behaviors. We're going to assess their mood and affect. We're going to assess for any suicidal ideation. We're also going to assess their sexual functioning because a lot of experiences of depression and antidepressant medications can decrease libido. We're going to assess the individual's memory. When individuals have extreme depression, they may have poor ability to concentrate and they may have difficulty focusing and making decisions. We're going to assess their behavior. And then we're going to assess their family's response. A lot of times, family members or those close with someone that's having severe depression can be very frustrated. They might feel guilty or angry with that family member because when people experience depression, they have that decreased focus, they have that decreased energy, and it may be harder for them to do their typical tasks, responsibilities, and things like that. So family members may wrongly assess them as being lazy, not willing to help out, or uninvested in relationships. So it's really important that we assess family response and support to individuals with severe depression. We can also use a lot of different depression scales. We want to make sure that we're using a scale that's most appropriate for our patient, meaning, can the patient read? Does the patient understand the questions? And does it apply to the patient's age? There's a lot of different depression scales out there. The ones that are used by hospital systems or healthcare systems can vary greatly. When we're doing our shift to shift assessment, though, we're generally just using a numeric scale from 1 to 10. So we're asking our patients on a scale of 1 to 10, with 1 being no depression and 10 being severe depression, how would you rate your depressive symptoms right now? While a lot of our assessment is going to be done through conversation with the patient, it is possible to get a lot of this information through observation as well. So observation of the patient's behavior, their hygiene, their day-to-day schedule, their weight changes, their appetite, all of those different things are going to be very important. When we talk about interventions for our patients, a team approach is most effective, meaning that we're collaborating with a lot of different disciplines to help the patient. And our goals of treatment is to reduce and control the symptoms, eliminate them if possible, improve their occupational and social functioning, and reduce any likelihood of relapse of depressive symptoms. We always want to approach psychiatric care, especially with depression, through combination therapy, meaning that we can use a variety of different intervention methods. Typically, this will be use of medications and some form of psychotherapy. With our different types of therapy, we can do psychotherapy, which is generally more short term, and that includes things like counseling. Counseling is important because it helps the patient to recognize, explore, and resolve any loss, role confusion, transitions, isolation, and social skill deficits. And it can also be used as an independent therapy or through group therapy. Cognitive behavioral therapy helps our patients to adjust their thought processes and behaviors that might limit social and interpersonal success. It can also teach them techniques like thought stopping and positive self talk to avoid any of that negative evaluation of things. It can also help them build life skills like activity scheduling, social skills training, and problem solving. Other types of therapies that we can utilize is pet therapy, art therapy, massage therapy, as well as exercise therapy. So things like use of yoga, tai chi, other forms of exercise. Things like acupuncture and meditation can also be used as types of therapy. And if psychotherapy and medications are ineffective, we can use more intense alternative therapies like ECT, transmagnetic stimulation, and phototherapy. Phototherapy is going to be much more beneficial when we look at individuals with seasonal affective disorder. As far as medications go, we've talked about this in the past, but we're typically going to choose the medication based on the patient's symptoms, their genetics, their culture, their racial and ethnic priorities, their prior medical history, their finances, the side effects, and their age. It can take a long time before an antidepressant starts working. It usually takes 4 to 6 weeks before we see a full therapeutic effect. If the medication is not effective in treating the depressive symptoms for that patient, we have to slowly wean them off of that medication to avoid any withdrawal symptoms. So finding a medication that's going to be a good match for the patient can be a very frustrating and long process. So if someone is having severe depression and it takes 4 or 5 years to find a treatment that's going to be effective for them, it can really worsen their depression quite a bit. They have created forms of genetic testing that can help indicate which type of antidepressant is going to be most effective. So, for example, CPG testing is a test that looks at the way that we metabolize drugs, and it also measures which genes respond best to different classes of medications, especially medications that involve serotonin transporter genes or cytochrome P450. There's a lot of debate as to whether or not this genetic testing is effective in helping find a good medication fit for that patient. And it's not usually covered by insurances. So it's not necessarily used often, but it is something that could be promising in the future. So when we look at the different classes of medication, we have our SSRIs, or our selective serotonin reuptake inhibitors. These tend to have the fewest amount of side effects because they only work on serotonin, which is one of the three neurotransmitters involved with depression. The typical side effects that we do see are diarrhea, cramping, and heartburn. Examples of SSRIs are Prozac, Zoloft, Paxil, Luvox, Celexa, and Lexapro. Our SNRIs are our selective norepinephrine reuptake inhibitors that work on both serotonin and norepinephrine. So we do tend to see a little bit more severe of side effects while they typically are not that severe. And they tend to be a little bit more effective when SSRIs don't work well for a patient. Examples of SNRIs are Pristiq, Cymbalta, Effexor, and Fatisma. NDRIs are also commonly used, and the most common one that we see is Wellbutrin. Wellbutrin has pretty low side effects, and it's typically pretty effective, so it's used quite often in individuals. Another unique side effect to Wellbutrin is it causes weight loss, where the SSRI and the SNRI can cause weight gain. So we will typically use Wellbutrin in our patients that are considered obese. And kind of conversely, we would not want to use Wellbutrin in our patients that have eating disorders or are underweight. Wellbutrin can also be given to help with smoking cessation. Our tricyclic antidepressants work on all three neurotransmitters. So the side effects are a little bit more severe and include sedation, weight gain, blurred vision, dry mouth, constipation, sinus tachycardia, decreased memory, urinary retention. And it's a lot more likely that the patient can overdose on tricyclic antidepressants. So symptoms of an overdose would be anticholinergic effects, delirium, irritation, and it typically develops within 12 hours. If you have a patient that overdoses on a TCA, the treatment would be to induce vomiting, gastric lavage, and any cardiorespiratory care is needed. The medications included in TCAs generally end in FANIL. So it's your anafranil, your tofranil. We also see amitriptyline, nopraminin, doxepin, Pamelor, and Vivactyl. MAOIs, or monoamine oxidase inhibitors, are used as a last resort because they have very bad effects when interacting with different medications as well as foods that have tyramine in it. When we have foods that have tyramine in it and a patient is on an MAOI, it can cause hypertensive crisis, which can lead to stroke and death. The side effects of MAOIs is it can have a lot of antihistamine effects, orthostatic hypotension, priapism, and examples of this are Marplan and Nardil. Other medications that we can use for depression are Remeron and Trazodone. While these are not antidepressants, they can be used to help patients that experience insomnia. With a lot of these medications, we want to encourage the patient to avoid eating grapefruit because it can interact with a lot of the medications. We would also want to assess if our patient is taking St. John's worts. And the reason for that is St. John's wort is a natural remedy to increase serotonin. All of the medications with antidepressants increase serotonin as well. If we increase serotonin too much, our patients can develop serotonin syndrome. So we wouldn't want them taking an antidepressant with that St. John's wort. As I mentioned, we do need to taper the medications. Dosages are often lower in children and older adults. We always want to monitor for that serotonin syndrome, which can develop within hours to days. It is more likely to occur when drinking alcohol as well. And in order to be diagnosed with serotonin syndrome, you have to have 3 of the following symptoms: mental status change, agitation, myoclonus, hyperreflexia, fever, shivering, diaphoresis, ataxia, and diarrhea. Another thing that I want to reiterate is that typically it takes about 4 to 6 weeks before the medication is fully therapeutic. We know that between weeks 2 and 4 of starting a new antidepressant, our patients are at increased risk for suicidal behaviors and suicidal thoughts. So while our patients are starting an antidepressant, we want to monitor them closely for any suicidal ideation. In addition to the medications and different forms of therapy, we really want to use therapeutic relationships to help our patients. And this is meaning that we're being supportive and culturally competent, that we're available during crisis, that we're aware of any danger that that patient might have to themselves or others, that we're providing education and support in regards to the illness, that we're providing feedback and praise when they're progressing, that we guide and help them goal set, that we support their patient's own strength and decision making abilities. And we also want to avoid being overly cheerful when speaking with someone that has severe depression. And the reason for that is sometimes they might see that as you mocking them. So we want to use a calm, supportive, and empathetic approach to our conversation. We also want to be aware that individuals with depression might have delayed thought process, and it may take them a little bit longer to respond to questions. So we would want to make sure that we are being patient in our conversation with them. Lastly, we would want to help our patients to build effective coping skills. In addition to the treatment of depression specifically, we're also going to do different symptom management. So for example, we know that there's appetite changes when it comes to depression. So we're going to assess their food intake and help them adjust to healthy appetite as well. So for example, if you have a patient that's not eating a lot or has limited appetite, you might do an assessment to figure out what some of their favorite foods are, that so that you can provide more appealing food for that patient and help encourage their appetite. As far as sleep goes, we can adjust the times that we give them sedating medications. We can also teach them different sleep hygiene methods, which we'll talk about in the next lecture. As far as energy goes, we can limit their ability for daytime napping. Exercise can improve energy, and we can provide them with energizing foods. If our patient has suicidal ideation, we're constantly assessing their safety and possibly placing them on one-to-one close observation. And what that means is that you have a staff member within arm's length of that patient at all times to keep them safe and to keep them from harming themselves. We can also use things like limiting their belongings and visitors. We would always want our suicidal patients to have a roommate because that encourages social interactions. It limits their courage and feeling that they're able to attempt suicide without getting caught. And it gives us an extra eye to keep an eye on that patient. If absolutely necessary, we can utilize restraints and seclusions if our patients are actively hurting themselves, and all lesser restrictive measures have been tried. As far as social interactions go, we very much want to encourage group participation in our patients with depression. Because it's very easy for them to spend a lot of time in their room, we may order a room lockout where they're not allowed to utilize their bedroom between 9 and 5 or whenever groups are occurring, and that encourages them to go to groups. We can use methods to help them increase their self-esteem and social skills. We can address any work functioning complications that they have. For ADLs, we want to encourage their hygiene and nutrition as well as cleanliness. For behavior, we want to reinforce good behaviors and limit any disruptive behaviors. For family relationships, we want to limit any family stress. We want to teach both the patient and the family member stress management and coping skills and refer to any support services as needed. We want to encourage that they keep family rituals and that they are able to talk and find resolution of any guilt and conflict. We want to help them identify strengths within the family and enhance their ability for communication. There are also other forms of depressive-related disorders, starting with Dysmorphic disorder, or formerly persistent depressive disorder. This is a less intense form of major depression, or less intense than major depression, and it's when the individual experiences depressed mood for most of the day, for 5 days a week, for a 2-year span in adults or a 1-year span in children. So it lasts a lot longer than depression, but typically the symptoms are less intense. To be diagnosed, the patient has to have 2 of the 6 symptoms, being poor appetite or overeating, insomnia or excessive sleep, low energy or fatigue, low self-esteem, poor concentration and decision-making abilities, and feelings of hopelessness. Premenstrual dysphoric syndrome or disorder, also called PMS, is another form of a depressive disorder. And this is when the individual has symptoms present for a majority of the months of a year that start the week before their menses and improve within 3 days of starting their menses. Um, the symptoms that have to be present is they have to have a total of 5 symptoms between 2 different categories, which are listed there, with at least 1 symptom in each category. So the first cluster of symptoms would be labile affect, irritability and anger, depressed mood and hopeless thoughts, increased anxiety and tension. And the other cluster of symptoms would be difficulty concentrating, decreased interest in activities, fatigue, appetite changes, sleep changes, feeling overwhelmed, and having physical changes such as bloating, pain, and tender breast. For PMS or premenstrual dysphoric disorder, we may prescribe birth control rather than an antidepressant. Depressive mood dysregulation disorder is when onset of symptoms occur by 10 years of age, so between the ages of 6 and 10, and the symptoms last for a year in length with less than 3 months without symptoms. And basically, what the symptoms are is temper tantrums 3 days a week or more. Mood between these temper tantrums is often angry and irritable. Since this is a pediatric diagnosis, we'll typically try and avoid using any medications, but if we are going to use a medication, we'd want it to be at a lower dose. And then lastly, we have seasonal affective disorder. And this is when the individual has major depressive episodes that begin in the fall or winter and they subside in the spring, and they have to experience this for at least 2 years. In addition to those major depressive symptoms, during the winter, they may crave carbohydrates, have weight changes, and decreased energy. When our patients have seasonal affective disorder, we try to utilize phototherapy as that's been found to be very effective. And we're also going to only prescribe medications for part of the year. So the individual may start medications in August so that they have that good 6 weeks for it to start working before fall and winter start. And then we would wean the patient off the medication when spring starts. So very closely tied to depression is suicidal ideation and suicide prevention. When we look at suicide, it's important to understand the different terms related to suicide. So suicidality is all suicide-related behaviors and thoughts regarding suicide. Suicidal ideation is thinking about or planning one's own death. A suicide attempt is a non-fatal, self-inflicted act with the intent of death. We do know that prior suicide attempts are a greatest predictor for future suicide attempts because people tend to feel comfortable with the same method. And it gives us insight into what those methods are and any pre-behaviors leading up to a suicide attempt. It also helps us to predict the seriousness or suicidal ideation or the likelihood that the patient's suicide attempt will result in death. Parasuicide is a voluntary attempt at suicide or a suicidal gesture with the intent to live. And this is more common in personality disorders and includes behaviors such as self-harm or cutting. Then lethality is the probability that a suicide attempt will be successful. It is based on the seriousness of the intent, and it's based on the planned method. So as I mentioned earlier in this lecture, males typically use more lethal or more violent means that are more likely to end in death, and that includes things like shooting or hanging, whereas females use less lethal means like overdose. It is important to know too that suicide can be disguised as other accidents. So vehicle accidents, homicide, and other accidents may be a suicide attempt that look like other factors. As far as statistics and risk factors go, we know that suicide is one of the 10th leading causes of death in the US, with at least 80 successful suicides daily. It is more common in mountainous regions, cold regions, and regions with shorter days. So if you look at that map here, Montana typically has the highest level of suicide attempts. It's a very mountainous region far north, so they experience a lot of the cold weather, shorter days, things like that. Same thing with Alaska. And then if you look at the map of the world, you see that that's also kind of a common trend there, that the northern most countries that have less daytime, as well as colder climate, typically have higher rates of suicide at all as well. The one exception to that is kind of the Canadian regions where we see actually lower incidence. And a main contributing factor to this is because they eat a lot of fish there. And we found that fish oil has a very protective factor in developing suicidal ideation. So if you have a patient that has a lot of suicidal ideation, they may have a fish oil supplement ordered in addition to their antidepressants. As far as child, adolescents, and young adults go, we know that children as young as 5 or 6 try to complete suicide, but they really lack the concept and finality of death. So it can be very sad. We do know that in the child, adolescent, and young adult population, it is more common in American Indians, African Americans, and Alaskan Natives. It may be due to things like poor social skills, poor school performance, family discord, more commonly related to substance abuse or bullying. And social contagion is when we see suicide occurring in groups. So, as I mentioned earlier, this is when one individual within a social group attempts or completes suicide, and then we start seeing suicidal behaviors in the other members of that social group or that social setting. Part of that might be because they're unsure how to handle their emotions, or they have poor coping skills, or maybe they all have experienced similar traumas that have led to that, but also because having the loss of a friend or the near loss of a friend can be a very difficult thing for someone that's an adolescent and really for anyone. And that can lead to suicidal behaviors that appear to be contagious within a group. In older adults, we see that spike in individuals greater than 75 that I talked about earlier. We also see that there's a peak between the ages of 45 and 54. And this may be due to a lack of progression in life, evaluating life purposes, growing old, financial difficulties, medical diagnoses, um, as well as other factors. As far as gender goes, as I mentioned, males are often more successful in completing suicide. However, females do attempt suicide more often. Females typically express that their suicidal ideation or suicidal behaviors are due to history of sexual abuse or trauma. And we do know that suicidal behaviors are more common in those that are unmarried or unsociable later in life. We also know that suicidal behaviors is a lot more common in the transgender population, and part of that is due to the stigma and the stress of the lifestyle, as well as possible identity confusion. So we do recommend that if anyone is um, undergoing any transgender treatments, surgeries, or if they identify in the transgender population, that they do receive counseling alongside their treatments so that we can help them to reduce any suicidal thoughts or behaviors. As far as psychological risk factors go for suicidal behaviors, we know that internal distress is a risk factor, as well as low self-esteem and low opinion of life's purpose, having interpersonal distress, having a history of trauma or abuse, having cognitive limitations like difficulties with problem solving, impulsivity, rumination, and hopelessness, having personalities that lend them more towards impulsivity, anger, reduced inhibition, and impaired judgment, being under the influence of substances, using emotion-based coping versus solution-based coping, and having previous suicidal attempts all increase the psychological risk factors for suicide. Social risk factors include family discord and divorce, parental neglect and abuse, parent suicide, poverty and unemployment, and growing up in foster care. We also know that there's a lot of warning signs that are often present in patients that are feeling suicidal. If you're using the Boyd book, the second edition, a lot of these warning signs are highlighted in box 15.3 on page 233. And typical warning signs that we see is expressing suicidal ideation, having substance abuse, purposelessness, anxiety, feeling trapped, feeling hopeless, having social withdrawal, having increased anger, having increased recklessness, dramatic mood changes. So, this is often very, very quick mood changes where you have someone that has severe depression and then suddenly they are happy and joyful, as well as giving away belongings. And a tool that we use to assess these warning signs is the acronym is path swarm. When we look at the etiology of suicidal behaviors, biologically, we know that these individuals often have low serotonin levels. And because there often is a family history, we believe that genetics plays a role in it as well. As far as personality types go, individuals that are often hopeless, depressed, isolative, people pleasers, more emotion based individuals, or those that easily experience guilt or shame are more likely to attempt suicide. Social theories include that individuals that lacked connectiveness, are single, never married, separated, or widowed, or are homeless are at increased risk of suicidal behaviors, as well as individuals that lack religious affiliation. So when we look at treatment of somebody that has, or I'm sorry, when we look at assessment of someone that has suicidal ideations, we really want to be very forthcoming with our assessment. We want to be very direct in asking, do you have suicidal ideation or do you want to kill yourself? A lot of people, and partially out of comfort, will ask, do you want to harm yourself? We discourage people from saying this because a lot of times someone that is feeling suicidal does not consider suicide as harm. They consider it as a way to end the pain. So we have to be very direct and clear in our wording by stating, do you have an intent to die? Um, the big fear with asking so outright is that if we ask someone if they have any suicidal ideation, that it might give them the idea. And really, research has shown that that's not the case and that it is safe to ask someone if they have thoughts of wanting to die. If they do have thoughts of wanting to die, we want to know the severity of ideation. So, do they have a plan? Do they have the means to carry out that plan? Do they have um, any previous attempts? Why or how were those previous attempts avoided? Um, if the patient has a plan, do they have the means to do it? Why do they want to kill themselves? Do they have any protective factors like commitment to family members or any goals that would prevent them from attempting or completing suicide? So, we really want to be mindful of all that when we're assessing our patient's suicidal ideation. As far as treatment goes, family response can vary. Um, If suicide is completed, meaning that the suicide resulted in death, family might feel guilty. They might blame themselves. They might feel shame or depression themselves. It can often cause dysfunction within relationships. And we would want to consider any family members as being high risk for suicidal behaviors as well. If the suicide attempt is not completed, the family members may be judgmental of that patient or they may be overly compassionate to that person. So, we always recommend family therapy following a suicide attempt. As with depression, an interdisciplinary approach is most effective because it expands our patients' resources and social connectedness, and it helps them to develop and hold accountable for any least restrictive measures. We can do something called case finding, which is identifying people who are at risk for suicide to provide treatment early. This is often done at things like work, school, and non psychological related medical appointments. And in this, we're assessing their risk factors, any previous attempts, any behavior changes. And this is why, when you go to your doctor's office for a physical or for any of your annual checkups, or if you go for any procedures, they will always ask you about depression and suicidal ideation, no matter what setting you're in. And that is because of this case finding. Once we find someone that is at risk for suicidal ideation, we would want to address any risk factors. We would want to put them on close observation, so that's that one-to-one treatment. Reduce any environmental factors that could lead to self-harm, like any belongings such as pencils, razors, shoelaces, belts, things like that. As I mentioned earlier, helping them to have a roommate, removing any stressors, any triggers for feelings of helplessness, starting them on an antidepressant. If they are actively attempting suicide, we would want to give them sedatives as well. Um, if they do attempt suicide, they may need any life saving measures. So, we do know that suicide attempts within healthcare settings is most common on a medical surgical floor, and the most common method that patients use is hanging. So, we really want to be aware of that and know that no matter what setting you're in, whether you're in a psychiatric setting or not, your patients can still be high risk for suicide, and you would want to make sure that you are providing them with a safe environment. We can also use things like ECT or alternative therapy, such as music therapy, pet therapy, aromatherapy, yoga, medications, exercise. Um, some hospitals use something that's called a commitment to treat, and this is having a patient sign a contract or making a promise not to engage in any suicidal behaviors, but rather to openly discuss their feelings. This is kind of an outdated practice as research has shown that there's not a whole lot of effectiveness in it, but some settings will still use that. We would want to provide our patients with cognitive behavioral therapy, counseling, and group therapy. If they're in an inpatient psychiatric setting, we would want to screen them for any contraband. And we also want to be careful in ensuring that we're thoroughly documenting. The reason why we want to be thorough in documenting any of our patients' thoughts towards suicide, any suicidal behaviors, any interventions to prevent suicide, any events leading up to a suicide attempt, any substance abuse, medications, and anything like that, is because it's important that we prevent suicide and are able to pass that information on to others. So, for example, if you have a patient that has suicidal ideation and they attempt suicide, you have that documentation of all the behaviors leading up to it so that when you have another patient that has those behaviors, you can be aware of properly intervening. But also because it's important to be legally covered in case anything happens to any of your patients. And now moving on to bipolar disorder, which is the other mood disorder that we talk about here in our psychiatric nursing course. So, bipolar disorder is extreme moods that could cloud any judgment or reasoning and interfere with functioning in relationships. One of the mood states is depression, which we've talked about extensively today, and that's the depressed mood, loss of interest in activities, loss of concentration, increased anxiety and irritability, as well as sleep disturbances. Where the other mood states are mania and hypomania. So, mania is an elevated, expansive, or irritable mood. The individual may experience grandiosity, which is an exaggerated sense of personal importance. Their speech is often going to be pressured and hyperverbal. They are going to have increased purposeful and goal directed behaviors, so they can be very productive in the beginning stages of mania. And they can also have increased engagement in pleasurable but also risky behaviors. So we often find that they're hypersexual, they have increased substance use, and increased gambling and spending money. We describe mania as occurring in 3 stages, with the first stage being increased psychomotor activity, labile mood, grandiose thoughts, sexual preoccupation, and promiscuous behaviors. If mania is left untreated, it can progress to the second stage, which is pressured speech and movement, flight of ideas, grandiose delusions, and hostility. Again, if it continues to persist and is left untreated, it can develop into the third and most severe stage, which is paranoid delusions, bizarre behaviors, incoherent speech, hallucinations, and increased risk of aggressive or violent behaviors. In addition to being present in bipolar disorders, mania can also be seen in other psychiatric disorders, metabolic disorders, with a CNS tumor, with lack of sleep, and it can be caused by certain medications. Hypomania is the third mood state that can be involved with bipolar disorder, and it's less severe symptoms of mania, so the patient is often very high functioning. So they have that increased elevated mood, they have the increased purposeful and goal directed behavior, but they don't quite have the risky behaviors, the lack of sleep, and things like that. So they rarely seek treatment because they are high functioning and it doesn't impair their ability to um, work effectively, maintain relationships, and take care of themselves. So, when we look at the DSM 5 criteria of bipolar disorder, they have to have at least 3 symptoms of mania that last over 1 week's period, and at least 4 more symptoms of depression that last over a 2 weeks period. I think a common misperception when thinking about bipolar disorder is that it could mean that you're happy in the morning, sad by the afternoon, happy in the evening, and that it's very quick mood state changes. But that is not the case with bipolar disorder. These mood states last, as this describes, at least 1 week and can last much longer than 3, 4 weeks as well. Individuals may go a couple of months, a couple of weeks, a couple of years in between mood states as well. And when we look at bipolar disorder, it doesn't have to alternate completely back and forth between mania and depression, but rather you could have a depressive episode, a year later, another depressive episode, a year later, a manic episode, 3 months later, a depressive episode, 6 months later, a manic episode. So it doesn't necessarily have to alternate back and forth. There are different types of bipolar disorder. Bipolar 1 disorder is when you have a manic or a mixed episode, along with at least one episode of depression. It can be classified as also having hypomanic behaviors, manic behaviors, depressive behaviors. It can be bipolar 1 unspecified, mild, moderate, or severe bipolar 1 disorder with psychotic features. And generally, it's not related to substance abuse or any other medical condition. So remember, bipolar 1 disorder, depression, and mania. Um, Bipolar 2 disorder is when they have depression as well as hypomania. So in bipolar 2 disorder, they never experience a manic or a mixed episode. Because hypomania is so high functioning, bipolar 2 disorder is very rarely diagnosed in society, and it's often misdiagnosed as depression because these individuals will rarely seek treatment for their hypomanic states. Mixed bipolar disorder is when the mania and depression occur at the same time. This can sound like it's counterintuitive. How can you have manic behaviors and depressive behaviors at the same time? But what it really is you have those depressive thoughts with the elevation and irritability of mania. So it's very uncomfortable for the patients. Patients having a mixed bipolar episode have very high anxiety, agitation, a lot of energy, a lot of irritability. And because they have all of this energy, irritability, and impulsivity with depressive thoughts, patients with mixed bipolar disorder are going to be very high risk for suicidal behaviors, and they may not show any of those warning signs that we talked about earlier. Psychothymic bipolar disorder is when you have low levels of depression with hypomania. This is often present for at least 2 years in adults and 1 year with children, with less than a 2 month break in adults and less than a 1 month break in children. Rapid cycling is when you have at least 4 mood states within 1 year. So that could be of depression, mania, hypomania, or a mixed state. This is the most severe form of bipolar disorder, and it is more common in women. Men more typically have bipolar 1 disorder. And then we have bipolar NOS, or not otherwise specified. And this is when an individual experiences symptoms of mania and depression, but they're not strong enough to meet the criteria of any other forms of bipolar disorder. So when we look at the different causes of bipolar disorder, the exact etiology is really unknown. There's a lot of different theories and speculations that focus on different things. So a psychological and social theories attempt to describe when an episode will develop rather than why an episode will develop. So we know that people often have a mood state of either mania or depression following high levels of stress, following a trauma or significant life changes, following drug use. And because of that, we really want to identify the triggers for these patients' mood states and help them to cope effectively when they enter any of those high stress times. Biological theories more often try and describe how it occurs. So we do know that having sleep disturbances can induce a manic state. We do know that there are seasonal changes, so depressive states are more common in the winter and manic states are more common in the spring. So there could be an effect of the sunlight that they have on mood. We also know that genetics is often a possible cause with bipolar disorder. It's a very heritable disease. We know that individuals that have certain illness or infections can lead to bipolar disorder as well. Substance use can lead to bipolar disorder. Marijuana, in particular, can lead to the development of psychotic symptoms and bipolar mania. Other things that can lead to bipolar disorder are electrolyte and hormone imbalances, which is why we kind of see a difference with men experiencing more mania and women experiencing more depression. And then we have the kindling theory. So this is kind of like a pendulum where the patient's first mood state in their first episode is often more subtle. They can often get back to their baseline with minimal intervention. However, once they're in that vulnerable state, their sub-threshold for stressors increases. So the next time they have an episode, they experience the symptoms more severely, and it's harder for them to return to baseline with minimal treatment. So each time they have symptoms of mania or symptoms of depression, it becomes more and more severe, and they require more and more treatment. Risk factors for bipolar disorder includes having a family history, previous occurrence of mood dysfunction, lack of social support, stressful life events, substance use, medical problem. We do typically see the onset of age being between age 21 and 30. And a lot of those are going to be very similar to depression as well. When we look at treatment of bipolar disorder, pharmacologically, we can either use lithium or an anticonvulsant, which when used to treat bipolar disorder, we call it a mood stabilizer. Bipolar disorder is one of the diagnoses where medication compliance can be very difficult, especially in our manic patients, because people like to be manic. They like the feeling of being manic, and they might feel that they don't need the medications, especially if they're being very productive and happy. So we do have to be very creative, and we have to empower our patients through encouragement and participation and collaboration with them in treatment. So this is one great example on how patient-centered care is going to be really effective. Lithium is our golden line therapy for bipolar disorder, and it's a salt that competes with sodium. So it basically the way it works is it allows norepinephrine uptake to occur, so the sensitivity of serotonin receptors increases. But because it's a salt that competes with sodium, we do need to monitor salt intake, sodium levels. If our patient is sweating a lot, they may need to drink more water. If they increase their salt intake, they may need to drink more water. And we have to teach them the proper fluid and salt intake to maintain good levels. Lithium is effective in about 70% of individuals, and treatment of lithium actually dates back to ancient Greece, but it does take time to build effectiveness, and it has a very narrow therapeutic index. So we do have to measure lithium levels pretty frequently in the blood, especially if our patient has been working out more and they're sweating more, or in the summer, if they're dehydrated, it can increase their lithium levels to toxic levels. So lithium toxicity is a risk. A therapeutic lithium level is between 0.6 and 1.2 milliequivalents per mLs. If a patient's lithium level reaches 1.2 to 1.5, that's the start of lithium toxicity. The first symptoms that we'll see is a metallic taste in their mouth, a hand tremor, nausea, polyuria, diarrhea and loose stools, muscle weakness and fatigue, weight gain, edema, and memory impairment. If the lithium level reaches 1.5 to 2.5, they start to develop symptoms that are very similar to delirium and include severe diarrhea, dry mouth, nausea and vomiting, incoordination, dizziness, sluggishness, giddiness, and vertigo, slurred speech, tinnitus, blurred vision, increased tremors, muscle twitching, asymmetric deep tendon reflexes, and increased muscle tone. If our patient's lithium level gets greater than 2.5, they can develop cardiac arrhythmias, they can black out, develop nystagmus, coarse tremors, fasciculation, hallucinations, oliguria and renal failure, peripheral vascular collapse, confusion, seizures, coma, and death. So it is a medication that is very dangerous. And like I said, we do have to monitor them and their lithium level to prevent any lithium toxicity. If the patient does not respond to lithium, as I mentioned, we can provide them with a mood stabilizer. So these medications do alter the seizure threshold, so we do have to monitor and adjust the medications as necessary. An example of these mood stabilizers are Depakote. With Depakote, we do have to also monitor any liver functioning and their complete blood count, and it is contraindicated in patients with a liver condition. It is another one that we have to measure the blood levels for it. And with the Depakote, it should be between 50 and 150 NGs per ml. And we typically measure that every 6 months when stable. Use of Depakote can contribute to development of pancreatitis, birth defects, and hemorrhage. Tegretol is another medication that we can use. Common side effects of Tegretol are dizziness, drowsiness, nausea, and vomiting. It can also lead to aplastic anemia and agranulocytosis, so we do have to measure their blood levels and temperature frequently. It can also lead to birth defects. And the blood levels of Tegretol should be between 8 and 12 NGs per ml. At first, we measure Tegretol levels every month, then every 3 months, and then every 6 months, and then yearly. Lamictal is the third medication, and we can use this most effectively for rapid cycling and depressed phases. So actually, we'll give this with depression as well to supplement any antidepressants. Lamictal can interact with Depakote. So if both are prescribed, Lamictal will be at a lower dose because Depakote decreases the rate of clearance from the body. And the medical emergency associated with Lamictal is Stevens-Johnson syndrome. So we need to monitor our patients for any rash-like symptoms, any fever, any breakdown of connective tissue. We can give our patients antidepressants. However, one thing we want to be aware of is if patients stop taking an antidepressant abruptly, they can develop rebound mania, and we want to avoid any manic states due to that kindling theory. If the patient does develop any hallucinations, we can give them antipsychotics. We may give them sleep aids, especially during manic phases where they may not be where they may not be sleeping for a while. We can also give them any medications to help treat side effects of the anticonvulsants or the lithium. Psychotherapy is another tool that we can use, as well as ECT. We can help them create a more low stress environment. We can help them with diet changes, especially related to that salt and water intake. But another thing is when patients are manic, they might not have the focus to stop and eat as frequently as they want. And because they are more hyperactive, they have a higher caloric need. So our patients are at great risk of becoming dehydrated or malnourished when in a manic state. So we want to find ways to increase their ability to have improved caloric intake. And one of the more common ways that we do this is providing them with finger foods, because if they are pacing the hallways or if they are being super active, they can at least have that with them as they go and they can eat it while they're moving around. And then we have our nursing considerations for our patients with bipolar disorder. As per usual, safety is always going to be our main priority. We do want to assess for any suicidal behaviors, especially with that mixed bipolar state. We want to assess any signs of aggression, any sexual promiscuity that can lead to things like STDs, unwanted or complicated pregnancies, especially if they're taking those anticonvulsants. We would want to assess for medication compliance and medication side effects, including any weight changes, tremor, any evidence of lithium toxicity, Stevens-Johnson syndrome, serotonin syndrome. As I mentioned in pregnancy, a lot of the anticonvulsants or mood stabilizers are dangerous during pregnancy. However, being in a manic state and doing a lot of drugs can also be dangerous. So it's one of those situations where the patient works with their provider to assess the benefits and the risk to decide which medications are really going to be effective for them. We are going to monitor those lab values that I talked about already. And then we also want to assess the effect that it has on their support system. So, for example, in a manic state with that increased risky behaviors, a patient may have increased gambling or spending, which can lead to financial implications. The erratic behavior can lead to job loss. It can also lead to lack of productivity in the depressed phases. It may lead to conflicts with their significant other, especially if they're having that hypersexual pressure and agitated behaviors. Um, Patients that act erratically may also be placing family and friends in compromising situations, which can increase conflict. And then we also want to assess their environment. So, a lot of times, patients that are in a manic state or maybe a severely depressed state might not have the financial means to maintain their living situation or the social interactions to maintain that. So, oftentimes, they may be kicked out of living situations. Another thing that I want to mention is our patients that are in a manic state like to wander, they like to pace, they like to walk a lot. And so we may need to assess things like skin integrity and hydration. If the patient has been walking for 3 days straight, they're going to have a lot of physical effects of that as well. And it's really important that as nurses, we're assessing and treating them holistically. And that is your lecture on mood disorders.